Hello everyone and welcome to EVMS UltraSoundbytes. My name is Suzanne Dickinson. I'm one of the instructors in the EVMS ultrasound program. Today we're going to cover the thorax, specifically the lung, and let's go ahead and get started. So our objectives for today's session is going to be, of course, our clinical application in a POCUS exam and our machine setups and our options for those setups, and the patient, how you want them to be lying down, and also the acoustic windows that you'll be using to obtain your images. We will go over the actual acquisition of the images, and we'll go over some pearls and pitfalls and the SPI snapshots. Okay. So for our clinical application, the purpose of doing a lung imaging is to evaluate for suspected pneumothorax, for pleural effusion, lung edema, and lung consolidation. For this session, we're going to be concentrating mostly on evaluating for pneumothorax with the use of some really common ultrasound artifacts, reverberation specifically, is remember that we can't actually directly see the lungs because they're filled with air. So we're going to rely on reverberation. And so we will rely on A lines, B lines, and lung sliding effect. And these are all artifacts that we see due to the reverberation artifact of the sound wave. So we want to also take advantage of what we know about pneumothorax, is that typically this will migrate, the air will migrate more superiorly in the superior aspect of the thorax, and remember that that air is within the layers of the pleura, and so we'll be looking in zone 1, and as you can see from this diagram, zone 1 is going to be that anterior superior chest wall. We also have several other zones of the anterior and axillary region, and that is zone 2, which is going to be below the nipple line. And if we then cross over the anterior axillary line, and between that and the posterior axillary line, we have our zones 3 and 4. So on the anterior surface of the body, we actually have 8 areas altogether, because that is duplicated then on the other side. On the posterior aspect of the body, which is not shown here, there are 2 other zones for a total of 4. But today we'll just concentrate on zone 1 so that we can cover pneumothorax. So a little bit about the A-lines and this specific reverberation artifact. And if you recall, reverberation is when the sound beam encounters some strong specular reflectors or gas or fluid bubbles caught in that reflector. And we can use that to our advantage. So as the A-lines will hit the pleural layers, it will reverberate back and forth within those lines. So as each reverberation returns that went back and forth within that line, we get a duplication of the pleural line. And it'll look something like this. So we have our pleural line, which is the true pleural layers, but the sound beam will get caught not only once, which you'll see then a linear line deep to it, which will be your first A line, but it might get caught in there even twice, and you'll see a second B line. But that's really dependent on how deep you are. So the A lines will be evenly spaced out, and if you're using other than a linear probe, you'll see many of these A lines going all the way down until the sound beam completely attenuates and can't return that artifact. So for our B lines, now the B lines will also arise from the pleural line, and it's not uncommon for us to see B lines. And B lines are not really an abnormal finding, but they can be an abnormal finding when there are many of them. So when they're foreseeing a lot of them, it's often because you're encountering this increased extravascular fluid or edema in the leading edge of the lung interstitium. So just like the waves will reverberate within the layers, if there's edema, there's even more for those waves to reverberating off of, and that's going to be that air fluid complex and the pleura. And as a result, we'll get these almost rocket or comet tail, they used to be called, like artifacts that can obliterate the A lines. So they'll manifest themselves in these laser-like bright lines coming off of the pleural line and extending all the way through to the far field. And you'll note that wherever they're going through, you can't really distinguish the A lines. They obliterate the A lines. But like I said, a few of these you're going to see, and it's not uncommon to see them. It's only when we see many of them where we begin to have some concern that there's edema of significance in the lungs. And where this can become important clinically is it can determine whether or not you're going to hydrate this patient or not, because that may have an impact on your clinical decision. Now, lung sliding is another reverberation artifact. So remember that these pleural layers are sliding back and forth, and there's serous fluid in them. And this serous fluid will give this impression of ants traveling across the pleura. And so these are these tiny reverberations between the serous fluid and those pleural membranes. And you can really see that movement. So this is normal lung sliding, and had our screen been a little deeper, you would have even seen the A lines on this, but we're concentrating on the pleura here. And so to be able to see that sliding, we want to get as close to it as possible. All right? This is often called well, let me go back a little bit. So if you'll notice that there is a shadow that is from each rib, because we were looking at the rib spaces. And I just want to point out that this is sometimes referred to as the bat sign. You may or may not notice that as bat wings, but it'll be sort of like this. And so that's how they're seeing it. So that's the space that you want to be in. You want to see a rib on either side and then see the pleural lining in there. All right, so for our machine setup, it's going to be the, as we have instructed before, you're going to be entering your information from Blackboard. And your probe selection for this session is going to be the linear probe so that you can see the detail of the anatomy. You want to be able to always practice while you're going through this learning process of being able to see the skin layer, the muscle layer, identify the bones, identify the intercostal muscles, and then really be able to look at how that pleura movement, that dynamic movement of the pleura. And so afterwards, however, you might want to practice using the curvilinear and the phase, because those may be the only probes that are available to you. And the curvilinear is really effective, including the phase, is really effective in the lateral lung fields, the more inferior and lateral lung fields, when you're looking for pleural effusion. So our preset is going to be small parts, and usually when you select the linear probe, it will default to small parts. And our depth and gain, as usual, you'll want to keep those at your default until you start scanning, as well as having the TGCs aligned centrally. You may have to adjust the more posterior TGCs, increase their gains a little bit in order to really appreciate the artifacts that you want to use for your diagnosing. So let's go back to the machine now and talk about patient position, acoustic windows, and image acquisition. And I'll also show you quickly where we're putting in the patient information for this session. So when we put in our patient information for this session, you're going to be just typing in lung here, because these are the image that you're going to be saving. And then over on the first name, you would put in, say, which class you're you're in. I'm just going to put MPA right here. And when you are done with that, you can select your OK button with the Set button, and you'll notice that the machine does default to small parts, and that is because if I select my exam, it's the first on the list and tends to go for that particular preset. There are other presets here like MSK and breast that use the linear probe, but small parts is the appropriate one for lung scanning. Now, if we talk about patient position, your patient in a trauma situation is going to be lying down, and most likely in this supine position that you're seeing now. And this gives you access to those anterior areas. So the anterior area is going to be above the nipple, zone 1 will be above the nipple line. Zone 2 will be below the nipple line on that anterior surface. If we go to the axillary area, remember we have an anterior line and we have a posterior line, and so if we use that same division that divided the first two, zone 3 would be superior and zone 4 would be inferior. And this is the zone also that's going to be very close to where you are with your hepatorenal interface. And so when you're in this lower zone, you're able to come down far enough where you can see that interface between the diaphragm, so that chest, the thorax, and the abdomen, and be able to look for pleural effusion, because the fluid, unlike the water, unlike the air for the pneumothorax, is more gravity dependent, and so you're going to look for those in the lower lung fields, which is why today we're going to be focusing on zone A, because the air is more likely going to move upward. Now that said, I do want to point out that if a little later we're going to be talking about lung point, and I'll describe the way you would find that lung point and moving in a lateral way across the body. All right, let's go ahead and take a look at our images. So what you're going to do, I tend to go ahead and palpate the clavicle, because I know that just inferior to that is going to be that first lung space that I want to see. And I'm going to place my probe on that lung space, and I'm going to unfreeze my machine. Here we have that intercostal space. I'm right over the clavicle. I'm going to drop down and try to bring the other rib in. And I'm going to decrease my depth a little bit so that you can better see these two rib spaces. And let's see also, I'm going to switch this to a trapezoid. Let's see if that will help us a little bit. Okay, so what I did there on the machine is that we have the option to spread our image out, or our field of view, by engaging the trapezoid, so that you can get the ribs on both sides. So I'm going to adjust for my depth just a bit. And you can really appreciate those ribs. Sorry. Come down another lung space so we can appreciate those ribs. And I'm going to stop right there. And I'm going to put my focal zone just down here by the pleura. Here's the pleural line. And as you can see, we've got rib shadow. And as you watch this pleural line, you can see that ants walking on a trail, if you want to refer to it that way, and this would be normal lung sliding. Now, for this patient, I'm going to move closer to her sternum so I can bring those two rib spaces together a little more. And then I'm going to freeze this image so that I can point out to you an A line right here. Now it's a little bit faded, because we're getting a lot of, she's very well aerated, we're really getting a lot of attenuation of our sound beam, but you can appreciate how we have this pleural line here, and then we seem to have a duplication of that pleural line here. Those are A-lines. So these are indicators of normal lung, and seeing A-lines can also be an indication of a wedge pressure that is less than 13, so within that normal range. If we want to appreciate our anatomy, we can see the skin layer here. We can see the subcutaneous layer here. We can see the pectoralis muscle here. And we can see the intercostal muscle coming across between each rib. Once again, our pleural line, and then our reverberation artifact here. And when we were in real time, our reverberation artifact that allows us to see this lung sliding effect. Okay, I'm going to freeze that for a moment. Let me come back to my slide. So I want to round out the clinical picture a little bit with lung point. When you find, when you're going to be scanning the lab, hopefully nobody has a pneumothorax. So let me explain to you what happens when you do find a pneumothorax, which is that lack of sliding. You need to work through each rib space going down in that zone 1 until you find the point at which you see normal sliding again. And that is called the lung point. Now, typically what you try to do is find that between the intercostal spaces so that you can actually see the normal lung movement inferior to the pneumothorax. And it's important to know where that lung point is because it gives you an idea of how large the pneumothorax is. Because if we recall that pneumothorax is going to, as it grows, is going to press or collapse the lung inward. And so this is where the moving out to the lateral portion of the zones is important, because as you move first laterally, you may find the lung point at your zone 3. Only if you don't find it there and you still move around to the other zones and still do not find that lung point. Now we're talking about a very serious pneumothorax that is a complete and total collapse of the lung, because we have no place to even intersect with the lung because it's completely pushed away from our probe. So let's talk about M mode for a moment. And this is going to be my SPI snapshot here. And I'm going to tie that back in to showing you that on our patient today. So when you have to document lung sliding, it's not always practical to save a cine loop of that lung sliding. Sometimes you need to just save a single image. And the best way to do that is we can take advantage of motion mode in our on our ultrasound machine, which looks at motion over time. It's a one-dimensional way of scanning, and it will allow us to demonstrate the lung sliding in a single image. So if we look at these images here, this has often been used in cardiac sonography, both adult and fetal. And looking at that bright dotted line that's moving across the anatomy at the top of each of these images, wherever that line is crossing, that anatomy is going to be displayed on that graph as as movement over time just of that line of sight. And so if we start at the top of our screen, we are encountering on this particular image, the leading edge of the right ventricle. And as you know, the ventricle itself is anechoic, and so that's mirrored on the motion graph as well, the leading edge will have your brightness, but the chamber itself will be black. So you'll notice that the next layer is just black. And then the layer after that, as we hit the interventricular septum, becomes all in varying shades of gray again. and then we hit the left chamber, and we should be hitting black again. There's some echoes within there because remember this is motion, and so the chordae tendineae happens to be at the level of this particular line, and so that's demonstrated. And then we finally hit the back wall of the ventricle, or that posterior wall, and again it's demonstrated across that bottom, and you see the motion by the peaks, that movement up and down. We do the same thing in the fetal heart, and indeed we even use this to calculate a fetal heart mode. So how would we then use this in order to use it for our lung sliding? Well, we have something called the sandy beach sign, and it is a sign of normal sliding. So the chest wall, which shows less movement, will have the lines will be quite flat, or I'm not going to use the term barcode right now because that's our next sign, but there is this layered linear aspect of the chest wall because there's less motion there. It is moving up and down with the chest movement, but not in the same way that we see the pleura moving. So the pleura shows a much greater movement. So it will appear quite granular, deep to those lines. And that's your sandy beach. So when you see this image, and in some machines that sandy beach might be a little brighter, or the echo's a little brighter within it, but on our machines, the Mindray M7, this is a typical appearance of the sandy beach. And you can see as that line hits the pleura, it creates a similar line across your graph, and then as it hits the air and all the artifact that comes with it, we get that nice granular beach scene. So this would be a way to document that there is normal lung sliding. So what happens though when you want to document the pneumothorax? Well, this is called the barcode sign. And again, we'll have those same flat lines of the chest wall because there's not a lot of movement there, but then there's not a lot of movement in the lungs either, or along that pleural line either. And remember too, the pleura has been separated, those pleural layers have been separated by the air, so there really isn't a way for the M mode to pick up that same nice granular sandy beach appearance, so we get that similar smooth linear appearance of what was going on with the chest wall. This is a sign of pneumothorax and a way for you to document it on a single image. Let's go to the machine and I can demonstrate the M mode. More gel. So as I get my image between the two ribs, I'm going to take out just a little bit of depth, and we can see that sliding movement. Now when I engage M mode, where if we look on our machine, the M mode is going to be located where all of the other color and B mode buttons are. And at the very far end, there'll be one that says M. And this is pretty typical on most machines. They'll use M. When I engage M, and I'm going to press that button now, we get a line down the screen. You can use your trackball and move that line across your screen. But I'm just going to keep it right in the middle of the intercostal space here. And then I'm going to engage it by pressing our update key. When I press update key, one of the things you'll notice here right away is that we really can't see much of a graph. The default on the M7 is a very low gains. So I'm going to go to my gains and I'm going to really crank those up so that we can see our M mode graph on the bottom. And as you watch the lines go across, its motion over time, I'm going to freeze it. And now you can see our sandy beach. So here's the skin line on the image itself. The skin line is going to be represented here, and then we start to go into the muscle layer, and you can see how we still have lines across here representing the muscle layer, and then even the last of the muscle layer, which is going to be the intercostal muscle down here, And finally, we're going to go into the pleural line right here and into the lung field. And you can see that sandy beach. And this would be an image you could document to show that there was normal lung sliding on this patient. And of course, you cannot demonstrate your barcode sign on this as this patient is clearly healthy. We don't want to even find that on her. Go ahead and cover this up here. There we go. All right, so that is ultrasound of the lung. Just staying to our zone 1 and just concentrating on pneumothorax. As you move through the program and begin to be able to apply the other concepts to edema, and you've already encountered how you would find pleural effusion on abdomen, you'll be able to make even more assessments using lung ultrasound. Now let's talk about some pearls and pitfalls when we are doing lung ultrasound. Actually, lung scanning is pretty straightforward once you understand the general concepts. And so, as usual, don't start scanning till you get all your presets and patient information in there, because documentation has to be done in a habitual way. And also make sure that your depth is set, and this is the linear probe, so that you're at least deep enough to appreciate the reverberation artifacts. So with the linear probe, probably just a few centimeters below. With the other probes, you may be a little bit deeper, but you still want to be able to appreciate those reverberation artifacts and learn about them well. Once you're comfortable with the anatomy, you should experiment with the curvilinear and phased probes, because they may be the only thing available to you when you're in an emergency setting, and you can still use N mode with those if you're in zone zone 1. But the other zones where you need to go deeper, you can still use all of the tools at hand for each probe. For your N mode, you do have to turn up those N mode gains. As you saw when I turned on the N7, its default for those N mode lines was pretty low. So just be aware of that you might want to, the minute you engage that N mode, to go ahead and start cranking up your grayscale. All right, so your SP cards for scanning, you're going to see those on the your blackboard, and we have a couple of slides in there, or cards in there, that will once again remind you of those A lines and B lines and what you can do interpreting those artifacts. Thank you for joining us for Ultrasound Bites, and we'll see you next time around.